Hello and welcome. Today we're going to be talking about paroxysmal nocturnal hemoglobinuria, which is a rare and a fascinating blood disorder. In this video, we will explore how PNH affects red blood cells and why understanding this condition is crucial for effective treatment. So if you're intrigued and want to learn with me, then feel free to hit the subscribe button and let's get started. All right, so here we are looking at a normal red blood cell right there that wants to protect itself from the complement system right here, which is a part of the immune response. So red blood cells are naturally equipped with various protective proteins. So we can see CD55 right there, which is also known as decay accelerating factor. We also have CD59, and these protective proteins play a crucial role in safeguarding the red blood cells from the immune response, specifically hemolysis that may be elicited by the activated complement system. So it is clear that the body must fit these protective proteins onto the surface of the red blood cell. So this is what we are looking at. You see this right there. This provides anchor. Okay, and we call that GPI. So GPI is glycosyl phosphatidylinositol, and it is essential for attaching CD55 and CD59 onto the red blood cell surface. There is a gene by name PIGA, a phosphatidylinositol glycan class A, right there. This gene is located in the X chromosome, and it plays a pivotal role in the synthesis of these GPI proteins that will help attach our protective proteins that we are talking about onto the surface of the red blood cell. So by ensuring the stability and functionality of CD55 and CD59, the PIGA gene helps maintain the delicate balance required for protecting red blood cells from unwanted distraction. This is hemolysis and ensuring overall cellular integrity. All right, so PNH is a rare blood disorder and is caused by a somatic mutation, okay, in the PIGA gene. Now, this mutation leads to a deficiency, or let me say, the inability to express these GPI anchor proteins. You remember they used to be somewhere there so that those protective proteins will be attached to the red blood cells, right? So there is the inability to express GPI anchor proteins. And so this means that there is no linkage, okay, of complement regulating proteins, that is CD55 and CD59. There is no linkage. Furthermore, the PNH red blood cell, as you see right there, is now being vulnerable to complement-mediated hemolysis. So as you can see, complement will not attack the red blood cells due to the lack of these protective proteins, and it leads to, as you can see, this is a membrane-attacking complex fit onto the membrane of the red blood cells because of the activated complement, and this leads to hemolysis. Okay, again, there is also going to be a nitric oxide depletion as a result of the hemolysis, and we will discuss that its implication in the clinical manifestations. Again, as we can see, this would also predispose to thrombosis. We'll also talk about that extensively, and this arises from a combination of factors, one being a complement-induced aggregation, as well as from the GPI defect. This can activate the platelets. All right, so in the clinical manifestation, just guess what? Thrombosis emerges as the leading cause of morbidity and mortality, with venous thromboembolic events being more prevalent than arterial ones. Notably, the hepatic veins are frequently affected, leading to Budd-Chiari syndrome. But thrombosis can also occur in other sites, even including the cerebral vasculature. Signs of hemolysis right here may include dark urine, jaundice, and pruritus. Additionally, the accumulation of pigments and hemosiderin in the renal system can also occur, which compromise kidney function and potentially lead to a failure if this is not addressed. So let me add that the dark urine that presents particularly in the early morning is a phenomenon that is related to the body's mild acidosis during sleep, as a result of shallow breathing. However, it is important to note that this classic sign may not be universally observed. During hemolysis, again, right, the consumption and subsequent depletion of nitric oxide can occur, significantly impacting vascular health. Nitric oxide, if you recall, plays a crucial role in promoting vasodilation and also facilitating the relaxation of smooth muscles throughout the entire body. So, when nitric oxide is significantly diminished as a result of the hemolysis, it leads to smooth muscle dystonia, particularly within the GI tract, and potentially resulting in symptoms such as esophageal spasm, abdominal pain, dysphagia, and even erectile dysfunction. PNH can also present with complications such as bone marrow failure, and this can predispose the individual to an immune compromised state. It is important to recognize stresses such as acidosis, surgery, or trauma, and even infections, as they can activate the complement system. All right, so in the investigation of PNH, we're going to start from here. That is flow cytometry, evaluating the expression of CD55, CD59 on the surface of the red blood cell is the preferred modality for confirming the diagnosis. Findings indicative of intravascular hemolysis may also include an elevated indirect bilirubin levels, increased reticulocytes, lactate dehydrogenase. There is going to be hemoglobinuria or hemosiderosis and a decreased haptoglobin levels. Additionally, a complete blood count, as we see right there, can also be very instrumental in evaluating for cytopenias commonly associated with the condition. Acidified hemolysis tests will be expected to be positive. Leukocytic alkaline phosphatase test will be decreased, and this tells us that this is a stem cell disorder that may even progress to one of the leukemias, for example. Renal and liver function tests provide crucial insight into organ health, while D-dimer may also help assess thrombotic complications. Additionally, a bone marrow aspirate can elucidate hematological features that are specific to PNH, and a cytogenetic analysis may also reveal underlying genetic abnormalities. Furthermore, imaging modalities such as a CT pulmonary angiogram, MRI, ultrasound with Doppler studies may be warranted to evaluate vascular involvement. All right, so the cornerstone of management for PNH focuses on blocking the complement pathway. Here I have provided an illustration of the complement pathway, and this is going to help us understand how some of these agents work, that is complement inhibitors. Okay, so a drug such as eculizumab, being a key medication, can inhibit the complement factor C5 right here and help prevent the formation of C5a and C5b, as C5b is a part of the membrane attacking complex. So the membrane attacking complex is what you see inside the red blood cell that facilitates the hemolysis. Okay, so eculizumab blocks it right here. It is also able to halt the formation of membrane attacking complex. However, its high cost and short half-life poses a challenge for cost effectiveness. So a drug such as ravulizumab, okay, offers a promising alternative due to its significantly longer half-life and enhancing patient convenience. So looking ahead, there is a potential exploration of additional complement targeting agents to further expand therapeutic options. Allogeneic stem cell transplant stands out as the only curative therapy for PNH. Corticosteroids can also play a valuable role in mitigating the hemolysis. Additionally, it is also wise to implement prophylactic measures against thrombosis, often utilizing anticoagulants to reduce the risk of thrombotic events. Iron replacement may also be necessary as the iron is lost together with the hemoglobinuria. Thank you, and I hope this was useful. If you enjoyed it, then hit the like button and subscribe to the channel. Bye.